Welcome to our mini-series on cancer therapies, Understanding the Options. Cancer is a complex and challenging disease, but medical science has made remarkable advancements in its treatment. Today, patients have access to a wide range of therapies, each tailored to target cancer in unique and effective ways. In this series, we'll explore some of the most innovative treatments available today, including hormone therapy, immunotherapy, targeted therapy, stem cell therapy, biomarker therapy, and CAR T-cell therapy. Through the insights of Dr. Samit Purohit, we'll simplify these complex therapies, helping you understand how they work and who they might benefit. Whether you're a patient, a caregiver, or someone looking to stay informed, this series is designed to provide clarity and hope in the fight against cancer. Let's dive in and explore the incredible advancements shaping the future of cancer care.
Hello colleagues, my name is Dr. Samit Purohit. I am Senior Director and Head Medical Oncologist at Action Cancer Hospital. I have a practicing experience of more than 15 years and I deal with most of the malignancies like head and neck, breast, prostate, colon and lung cancers, and I see hematological malignancies as well. When you come across a term like therapy means to get rid of cancer or to control cancer. So in allopathic terms, therapy usually means a systemic form of treatment which will affect your system. It is different from surgery and radiation. So a systemic form of therapy which will affect your whole system can be divided into chemotherapy or it can be a targeted form of therapy. Now targeted form of therapies can be hormonal therapy, it can be other targeted therapy, or it can be immunotherapy. The difference between chemotherapy and other forms of therapy is that chemotherapy targets bad cells as well as good cells. So it is like a bombardment. You throw a bomb, the bad cells are killed and so are the good cells. But in targeted form of therapy, the bad cells are primarily targeted and the bad cells, they usually escape. So targeted form of therapy is a better form of therapy with less side effects. So it depends on the stage of the disease. For tumors where we feel that surgery is difficult to contemplate or to do surgery is difficult right now and the tumor has slightly spread. So with chemotherapy, we try to bring down the disease bulk. We make the disease from this much to this much. So it is much easier for surgeon to operate it and to have a very clear margin. So we give chemotherapy initially. It may be 3 months of therapy, it may be 6 months of therapy. We do a scan after 3 months and 6 months. When the tumor has shrunken, which means it has become to the size where it was 6 months before. So when it becomes really small, we go ahead with the surgery. So this is new adjuvant. You give treatment before surgery. Sometimes you give treatment after surgery also when you have done the surgery and the pathologist and or the treating oncologist feels that there are chances of relapse, that the disease may have spread to microscopic veins, blood. So then we give an adjuvant form of therapy which is given after surgery, and this is again given for a period of 6 months. So recovering with only chemotherapy is possible in certain blood tumors. In like blood malignancies, only chemotherapy is usually sufficient. Sometimes in certain other solid malignancies also, only chemotherapy is usually sufficient. However, in most of the malignancies, chemotherapy is usually added over surgery or radiation. But you have to see what kind of primary tumor the person is having. So whenever the diagnosis of cancer is made, we first see what is the type of cancer, what is the histology, then we see what is the stage of the disease. Based on these parameters, we decide which therapy has to be given to a patient. Also, we see the fitness of the patient and how are his end organs, like how is the liver function, how is the kidney function, how is the heart function. Then we decide what amount of dose needs to be given to that patient. So the same tumor in two different patients will have different doses, and there may be a chances that we may offer different drugs also. So it is based on the tumor characteristics and the patient characteristics that we decide which kind of treatment or which kind of chemotherapy we have to give. Therapies can be different in most of the cancers. For example, I'll take an example of breast cancer. So females usually have breast cancer, but 1% of males can also have breast cancer. So the treatment more or less is same for them, but the same tumor in different individuals can call for different type of chemotherapies. Again, we have to discuss. We have a tumor board in our hospital where a surgeon the radiation expert, along with me, the medical oncologist, pathologist, the nuclear expert, we all sit. We discuss what type of the cancer it is and what is the best way forward. We have to do a surgery before or a chemotherapy before, and what is the sequence of treatment we have to offer. So that is how it is decided. So we have discussed two types of therapy. One therapy is chemotherapy. Chemotherapy acts on fast growing cells. So fast growing cells are cancer cells. But once you try to hit these cancer cells, the other fast growing cells in the body are usually affected, and this is where the side effect happens. So the other fast growing cells in the body are hairs. They may be your gut, so people may have nausea or vomiting or loose motions. The third type of fast growing cells are blood cells, so people may have fallen blood cells, platelets, hemoglobin. So these are usually managed with adequate nutrition and adequate supplements which we give along with chemotherapy. The other form of therapy, the targeted form of therapy, has usually very less side effects and they are easily manageable. So therapy is usually very important. People have this fear that if they have to undergo chemotherapy, it will be very painful, but it is not true. Nowadays, the chemotherapy medicines are very safe. They are very easy to take. The incidence of nausea, vomiting is very low. The incidence of post chemotherapy fall in blood counts is again very low. So if I compare the chemotherapy 10 years before and now, the side effect profile has come down drastically. So previously, if I were giving chemotherapy to 10 patients in a day, almost 7-8 were having side effects. But now that side effect profile has changed. Out of 10, only 1, 2 or at maximum 3 will have some sort of side effect.